Okay, hey everybody. This is Barry Servette, and I'm the medical director for MCPAP, and it's my pleasure to welcome everyone. Thank you so much for joining us at our monthly program, which is called Clinical Conversations. Takes place on the third Tuesday of each month. Today's topic, we're really excited about this, is suicide prevention in pediatric primary care. And I want to start with a couple of housekeeping issues before I introduce our speaker. First of all, the session is going to be recorded, so it will be available on the MCPAP website at www.mcpap.com. So tell your friends, and if you find it interesting and useful, feel free to pass that along so that people can listen to it and watch it. A copy of the slides is also going to be available on the MCPAP website under the Tools and Resources page. Our presenter is going to stop for questions as needed during the presentation, and we're really hoping to be able to have some discussion and to hear from you. So the way this works is that you need to type a question into the question box during the presentation. We'll keep an eye on that, and we can read out your question or unmute your line if you wanted to ask it yourself. And you can just indicate that in the question if you want that to happen and if you would prefer that. You will receive a brief survey at the end. We appreciate your feedback so we can improve future presentations. So today's speaker is Michael Schoenbaum, who is the Senior Advisor for Mental Health Services, Epidemiology, and Economics in the National Institute of Mental Health Division of Services and Intervention Research. He conducts analyses of mental health burden, service use and costs, intervention opportunities, and other policy-related issues in support of the Institute's decision-making. And he works to strengthen NIMH's relationships with public and private stakeholders to increase the public health impact of NIMH-supported research. So again, please feel free to enter questions into the question function on the console for the Zoom interface, and we'll go right ahead and get started.
Thank you, Barry, and thank you all for devoting this session to this topic. I will try to make the case for why it's important from a clinical and public health perspective, and also why there are real opportunities to do better. In any case, I'm grateful for the chance to talk with you all. Next slide, please. I want to start with some disclaimers. First, I am not aware of any conflicts that I need to disclose. Second, I work at the National Institute of Mental Health under a mandate from our director that NIMH needs to contribute both to the science and to the practice of suicide prevention. Nevertheless, I want to acknowledge that my comments today do not necessarily reflect the views of my employer. Third, I am not a clinician. In fact, I'm not even a mental health specialist by training. I'm an economist and epidemiologist. I have worked on suicide risk since around 2008, when the National Institute of Mental Health started working on that topic with the Army. And I continue to work on this with military and veteran populations, but now also and increasingly in many general population settings, not least because the national trend across all demographic groups now is in the wrong direction, unfortunately. A few additional disclaimers that aren't on the slide. So disclaimer number 4, our toolbox for suicide prevention definitely does not contain everything we would wish, but I think it contains more effective tools than people think, and especially tools that can be used by general medical providers, not just in behavioral health specialty care. Still, what I'm going to talk about today is supported by different degrees of evidence. For instance, we have more evidence from emergency care settings than from primary care, and we have more evidence on adults or on patients overall than on kids. I will try to be clear about this along the way, but in case I am not always, please remember that disclaimer, that what I'm going to say is all as evidence-based as it, as we currently see it, but we don't yet know as much as we want to know. A fifth kind of personal note. I've been working on this, again, as I said, for more than 10 years now, and it has always seemed urgent in many ways and highly motivating. 3.5 years ago, it also became personal in a way that it had not been when my best friend from high school died by suicide. And I mention this for multiple reasons now, partly because NIMH encourages people to talk about it, because talking about these experiences helps reduce stigma, especially around help seeking. I also talk about it to honor his memory, of course, and to acknowledge imperfection in myself and in the world. I know more about suicide prevention than many people, and still, when it came to text messaging, across the country at 4 a.m., I evidently didn't know what to do. So I want to acknowledge that, and I want to emphasize more broadly that in my view, the goal of suicide prevention isn't perfection. Perfection, in my view, isn't achievable. It's to identify better practices, to use them as widely as we can, to see where that gets us, and then to pursue additional improvement. One final disclosure, I've moved more and more away from presenting with slides, but here I can't see the audience, and I thought you might want to look at something, so I'm using slides, but I may be out of practice with that. So, next slide. This plots, what you all may have heard, what may for many of you be the kind of the newspaper point of entry into this topic, that the rate of suicide is rising, particularly in girls. So this slide shows that the rates for girls have approximately doubled since 2007. 2007 is in the middle of the slide. Across the whole adolescent age range. I should say suicide risk is also relevant in kids younger than 10, but in absolute terms, such deaths are so rare that the Centers for Disease Control, where I get these data, masks a lot of the cells, age, year, sex cells, for privacy reasons, because the cell counts are too small. And so it's important to talk about clinically, but it's difficult to plot. Actually, that point about rare in absolute terms is also true for older kids. These are, fortunately, rare events in absolute terms, but of course, they're catastrophic. Plus, there are many more attempts than deaths. Typically, there are, let's say, 10 attempts for every death. And attempts are also serious events. In any case, next slide, please. This figure adds boys. So you'll see that by older adolescents, there is a large difference between males and females that extends through the entire adult age range as well. Suicide deaths are much more common for males. Such as we have good data on attempts, attempts are actually somewhat more common for females than males. I think in particularly, we don't know the why of a lot of this, but I think a big reason for the fact that females attempt at higher rates than males, but males die at higher rates than females, has to do with sex differences in the methods people use for deliberate self-harm. Anyway, the figure shows clearly the suicide rate has risen substantially for both sexes and both of the age groups that I plot here since 2007. Why is that the case? We don't really know. And I'm mainly not going to try to talk about the why of suicide today. I'm going to talk more about the who and when and what we might be able to do to help. Next slide. First, a rant. This is the top of the first page of a recent paper publishing the results of a survey of pediatric residency programs about their suicide prevention content. In short, only around half of pediatric residency programs reported having any suicide prevention content at all. The researchers surveyed at least 2 people associated with every program, the director of the program and the chief resident. So around half reported having any suicide prevention content at all, and only 2/3 of those, which means in total only 1/3 of programs overall, reported that they had mandatory suicide prevention content in their curriculum. So 1/3 of programs had mandatory content. And the median hours of suicide prevention content among programs with any was 3 in a multi-year training program, which is literally half of the 6 hours that the state of Washington recently started requiring that all practicing clinicians of any type in the state receive periodically as continuing education. Which means, if these data can be believed, that I have had more training than the typical pediatrician received during residency, because I've sat through the state of Washington's training, among other things. In any case, perhaps we can agree that the field can and should do better. On the plus side, when the researchers asked about the barriers to doing more in pediatric residency programs, almost nobody, only around 10% of the programs, identified the lack of effective interventions as a barrier, which is to say respondents evidently are convinced that effective interventions exist, which I think is really encouraging since I also think that's true. Finally, I should mention, I actually work with folks who offer this type of training, including 2 residency programs. And their recent experience has been that the residents want it. They ask my colleagues for more help with this when the colleagues are on site, but that the program leadership is typically not so interested. So next slide, please. In concept, all of our efforts to do better by way of suicide prevention can fit into one of 4 categories. We can be better at keeping people from becoming suicidal in the first place. When people do develop suicide risk, we can identify them faster and/or identify more of them than we're doing now. Third, given that we identify someone with suicide risk, we can do a better job of providing existing treatments. And finally, we can develop and ultimately deliver better treatments. I'm going to try to talk about at least a bit about each of these, with much more emphasis on the first three than on the fourth for a variety of reasons, starting with my expertise. Next slide, please. So by way of primary prevention, which is to say primary prevention for suicide risk, for many people, the path to suicide goes through mental health or substance use problems. This isn't strictly true. You know, it's not universal, but it's quite common. The forensic autopsy, you know, the psychological autopsy literature, when people are interviewed post-mortem about the decedent's mental health status pre-mortem, you know, not surprisingly, a very high fraction of decedents are described as having mental health issues. That's squishy, in my view, because the people being interviewed about the decedent are all seeing the world through the lens of the tragedy that occurred, right? They know what the outcome was. Evidence from the CDC's National Violent Death Reporting System and from a few other platforms that have examined this have told us recently that about half of suicide decedents have a history of recorded psychiatric diagnosis. That doesn't mean the other half didn't have mental health problems. It meant that, you know, some fraction of them had them, but they weren't identified. In any case, given all of this, one strategy is to be better at identifying and treating behavioral health conditions, ideally so that people get better before they become acutely suicidal. What I've put up here, and we'll talk about briefly, but not, I suppose, belabor, is the specific care delivery model that has the strongest evidence to support its effectiveness, the collaborative care model, capital C, capital C. If you ask primary care providers, when I talk to primary care providers of all kinds about, you know, integrating behavioral health into primary care, they almost everybody says they do that. But in practice, not all approaches to integration are supported by the same degree of evidence. Indeed, the modal thing that primary care providers mean when they refer to integrating behavioral health in primary care, I don't know if this is true of pediatrics, but it's certainly true for general adult primary care, is an approach to integration that involves co-locating a behavioral health provider into the primary care practice, which has a number of benefits potentially for patients and also for the primary care providers. But what it hasn't been shown to do is improve patient outcomes. Whereas the collaborative care model, again, capital C, has been shown in something like 100 randomized control trials to improve patient outcomes. So collaborative care differs from, it extends usual primary care, including pediatric practice, by adding two types of people and a kind of workflow. The diagram shows this. So the first type of person added to the model is a care manager whose job is to be kind of the glue between the patient and the care team in terms of initial patient education, shared decision-making in deciding on a treatment plan for people identified with a treatable behavioral health problem, and then ongoing monitoring of adherence, tolerance, and response to whatever the treatment plan was. The second type of person that gets that is part of the collaborative care model is a psychiatric consultant. Doesn't have to be a psychiatrist, but a mental health specialty provider whose job is particularly to advise the primary care team about individual patients who are not adhering to or tolerating or responding to the current treatment plan, to advise about adjusting treatment. And then the workflow is measurement-based care and treatment to target, driven by a patient registry, little r registry, where it is just a mechanism for identifying who in the practice is being treated for a behavioral health problem and what the treatment plan is, and drives regular check-ins with the patient, drives recurrent measurement of the patient's clinical progress, and prompts adjustment of treatment for patients who are not meeting their targets. So the slide lists CPT codes that were introduced in 2018. Medicare added payment for the collaborative care model using HCPCS codes in 2017, and following Medicare's action, then these three codes were added to CPT. Medicare obviously isn't relevant for pediatrics practice, but fortunately, quite a lot of commercial payers now have said that they have turned on payment for these CPT codes for primary care providers, which should include pediatricians who want to use them. I don't know. So a higher fraction of large commercial insurers have reported turning these codes on than state Medicaid programs have reported. It has been done in some state Medicaid programs. I meant to check on the status of Massachusetts. I actually don't know currently about Massachusetts. So one other thing I guess I was going to say here about treatment, in this case not of suicide risk but of behavioral health problems, that I know is relevant in pediatrics is the black box warning on antidepressants. So, maybe the modal, I don't know, there are lots of behavioral health conditions that adolescents present with, but depression is a common one, and of course there is a standing practice recommendation from the U.S. Preventive Services Task Force endorsed by the American Academy of Pediatrics for regular screening of pediatrics patients, I think 12 and over, for depression. So we get asked a lot about antidepressants in the context of suicide risk. And as you know, I think more than 10 years ago, the FDA introduced a black box warning about this for the use of antidepressants in young people. Advocates of the black box hope that it would reduce suicides, but in my view, there is no clear evidence that it has done this. On the other hand, opponents of the black box feared that it would reduce antidepressant prescribing in young people, and indeed it did slow the rising rate of antidepressant prescribing in young people, and further that this change, the inhibiting prescribers from offering antidepressant medication, people feared that that would increase suicides via more or undertreated depression. And notwithstanding the fact that the suicide rate is rising in young people, in my view, there is also not currently any clear evidence of a link between the antidepressant prescribing or the black box warning on antidepressants and suicides in young people one way or another. So my takeaway is, frankly, to follow the instructions in the black box, to provide antidepressant medication when clinically indicated, and to monitor the patient proactively, which is the practice recommended by the FDA and which the collaborative care model is specifically designed to make happen and make easier. Okay, next slide. So the second category of intervention, the next way to do better, which is specific to suicide risk, is a better case identification. So very broadly, the usual methods by which we identify people with suicide risk are either we cross our fingers and hope that people self-identify, or we hope that somebody, a roommate, a friend, a family member, a teacher, a chaplain, a health professional, somehow figures it out. These methods are essential. Of course, we need to keep encouraging this and hoping that it works. But we have learned that these methods are not enough. So we have learned a fair bit about additional tools in this particular toolbox. In particular, it turns out that there are people who will endorse feeling suicidal, but only if one asks. In general hospital emergency departments, asking everybody about suicide risk, everyone, which is to say everyone age 10 and over so far, about suicide risk approximately doubles the number of people who are identified who need treatment for suicide risk compared with focusing only on the people with apparent self-injury or self-reported ideation or other evident behavioral health problems. And another setting where universal screening is particularly valuable is pediatrics, at least with all patients age 10 and over, and I'll come back to that in a minute. The issue in pediatrics is that the first presentation of behavioral health problems in an adolescent or a young adult may take the form of suicide risk, right? In adults, that's somewhat less common. In adulthood, you know, a relatively high fraction of people who at any point in time or have acute suicide risk also have some prior history of mental health issues. But in pediatrics, the kids, you know, because of age of onset and care patterns and so on, it may be that the first time that you have occasion to be aware that a kid is struggling, they are already, that struggle includes or takes the form of suicide risk. I mentioned before about age 10 and over. We do have evidence for at least for people age 10 and over that it is safe to ask about suicide risk, that there is no evidence that asking has iatrogenic effects. It's true. That's true for screening in clinical settings. It's also true, you know, in the wider world, in people's private lives, or in school settings or whatever. That you know, if someone seems to be struggling, it is safe to ask. Now, I hedge and say ages 10 and over because we actually don't know exactly about this in younger kids. We haven't tried it so far. We haven't really tested universal screening in kids under age 10. There is some, you know, their sense of self and their sense of what, you know, death and other things is developing, obviously. And so I want to hedge. It's not that we have evidence that engaging kids under 10 necessarily could put ideas in their heads. It's that it's not something that we have researched yet, and so I'm hedging a bit about that. So the rest of what I'm going to say in this section really, based on available evidence and practice experience, is for kids 10 and over. So in people 10 and over, it is safe to ask, what are we, and we, you know, we know in emergency department settings that we double the number of people we find who need help. We don't yet know that either that, the value added of doing it in pediatric settings, because so far we haven't yet made it to, we have universal screening programs in pediatric emergency care, but we don't very widely yet have, and we don't have research evidence from universal screening in pediatric, general outpatient pediatrics. So we don't know what the yield rate is. Anyway, I want to comment briefly what the goal is. How do we judge if screening is adding value? What I would argue is that the goal of screening is to assign people to categories. One category is no evidence of elevated suicide risk, move on to other things. And the second category is apparently elevated suicide risk, needs additional evaluation and maybe treatment. That is distinguished from, the goal is really not to identify the individual ticking time bomb. In my world, where I engage with the Joint Commission and with different professional societies and training programs and other people on screening for suicide risk, people often come back and say, well, but the positive predictive value of existing instruments is low. And what they mean by that is that any method by which one tries to interact with a patient to gauge their suicide risk, a very high fraction, a very low fraction of the people identified via any currently available method would in fact not go on to die by suicide, because suicide is in absolute terms a statistically rare event. So it's true in technical terms that existing screening tools have low positive predictive value, measured in the sense of the fraction of the people who are positive on the instrument who would go on to die by suicide. I would argue that isn't the goal. The goal is to identify people who are struggling and need help. And that the scope of what we prevent when we look for this kind of risk this way and offer people help, it includes reducing downstream risk for suicide death, but it also includes reducing risk for non-fatal suicide events, and also for other associated problems. It turns out we have now observed in multiple settings and multiple populations that people at risk for suicide are also at risk for other adverse outcomes, particularly accident deaths, including but not only substance use overdose accidents. So in any case, I want to emphasize the goal is not really to identify the ticking time bomb. The goal is to identify the people in your practice, the kids in your practice who are thinking about suicide risk, and who warrant treatment by usual clinical standards, but who won't reveal that, won't be detected unless somebody asks. So the slide shows one particular instrument for screening kids, the ASQ. This was developed in part by NIMH, and it was has been tested in various settings. Initially in pediatric emergency care, now also in inpatient and in general outpatient pediatric practice. What we've learned from that is that this instrument is clinically valid, which is to say that the results compare very directly with results from a comprehensive clinical interview. So you get the same categorization of needs more attention or move on from this handful of questions as you would get from a comprehensive clinical interview. It has good psychometric properties. The kids understand and are able to answer the questions. It's feasible to use this in various care settings, including, based on our experience so far, general outpatient pediatrics without disrupting the patient workflow. And it is acceptable to children and parents. Indeed, in focus groups, kids express overwhelming support for care providers asking kids about suicide risk, either in the form of they themselves were glad to be asked, and or in the form of well, even if it wasn't important for me, I think it's important that you are asking kids, because I know kids it's important for. We have found this quite consistently in the places we've piloted this kind of screening. Finally, I want to emphasize the ASQ is only one tool. There are others. The most commonly used is the Columbia Suicide Severity Rating Scale, which is longer. But one could also use, for instance, PHQ-9 item 9, which is shorter. It's one item. What you can't do, since I mentioned before about depression screening, what you can't do, we have evidence on this, at least in general, in the population overall, is you can't only screen people for depression and then screen for suicide risk only in people with a positive depression screen. So a PHQ-2 followed by PHQ-9, including item 9, only for people with a positive PHQ-2 misses too many people with suicide risk. So if your standard practice is to screen for depression using, say, a 2-item depression screen, I would suggest updating that to a 3-item screen, the PHQ-3, let's say, right? Items 1, 2, and 9, so that everybody gets asked about suicide risk, whether they're positive on the 2-item depression screen or not. Finally, we have evidence supporting a number of specific tools as primary suicide risk screener, but we don't yet have evidence of their performance compared with each other. So I put up the ASQ here for a number of reasons, including it's the one that's been tested most extensively in kids, but there are multiple tools that have been shown to be valid and can be used in real-world practice and so on, and I wouldn't claim that we have evidence that one is inherently better than others. Okay, next slide.
Michael, we also just have a question, if I could ask.
Yeah.
This person asked, how does the screening tool compare to the PHQ-A for teens or Ph.D. Filled out by parents? They find very poor correlation between both of these and what the teens tell me when I ask them verbally or in private.
So I should have looked up the PHQ-A. I believe that the PHQ-A is broadly structured like the PHQ-9, which is to say there's a question at the end about suicide risk. There what I would say is, asking explicitly about suicide risk is better than not asking about suicide risk. Whether that is the best instrument to do it, I don't know. What I would say is to concur strongly with the way I understand the comment, which is that asking parents about kids isn't a substitute for asking kids. In the places I've been involved in where we piloted the ASQ, including in outpatient pediatrics, the standard workflow for screening kids for suicide risk is to ask the parents to step out and then to administer the screen to the kid. If the kid is positive, then it depends on the age of the kid and it depends on the state what happens after that, because the age of medical consent varies, right? If the kids are below the age of medical consent, you're obligated to tell the parents. If the kids are above the age of medical consent, you're obligated to get the kid's consent to share the information with the parent. It is consistently in our experience, parents, when it is presented as part of a standard screening practice, parents are invariably willing to step out. If the parents aren't willing to step out, then the next step would be to screen in the presence of the parents. The final thing, I guess, is to say, I would err on the side of sensitivity. So if a parent reports that a kid seems to be distressed, I would act on that and seek additional information from the kid. But if a parent says, nothing, I'm not aware of any problem, I don't think there's any issue, that isn't evidence that the kid might not be struggling. And in fact, I think there is evidence, although I can't put my finger on it right now in this conversation, there is evidence that some substantial fraction of screener positives in kids are news to the parents. I hope that helps. So next slide. Hello? Oh, yay. All right. So I think the biggest barrier to wider screening don't look at this slide. The point is to show you a workflow, not for you to read the workflow necessarily. You can do that offline. I think the biggest barrier to wider screening for suicide risk is uncertainty about exactly what to do when someone is positive, which is obviously a bad situation for all of us to be in because we can't help people if we don't find them. And so we don't want to be deterred from finding them because we don't know what to do if we find them. So the point of this slide isn't to define exactly what your workflow should be. It's that it's really, really important to have an established workflow for what to do when someone screens positive. Still, a few general points. The first, and I think I really want to emphasize this, is that a positive screen does not automatically mean that the child needs to be put in an ambulance and sent to the emergency department or the hospital. Indeed, we don't actually have evidence that hospitalizing people for suicide risk improves their outcomes overall, although I understand that sometimes it's clinically and perhaps legally unavoidable to hospitalize. Still, there's some reason to worry that hospitalizing people could also cause them some harm. Plus, we do know that if people worry that they will be seized and hospitalized if they disclose suicidality, this inhibits help seeking. So I mentioned before that the goal of screening is to put people into two categories, right? Move on or needs more attention. In practice, a positive screen also ends up in two categories: people who need additional help but who can be treated in an outpatient setting, right? Which means they can go home if you attend to them properly. And a smaller number of people whose apparent risk is so high that they really do need to be treated whether they want it or not. In emergency care, where we have data on this, the cases break out around 4 to 1. So 80% are in this. You can discharge them properly and treat them in outpatient, and 20% of them might need the hospitalization, safety measures. That kind of like don't let them leave. We don't know how this breaks out in general pediatrics yet. There are standardized methods for doing this assessment. And I point to some of that in this slide, but I'm not going to talk about them in detail. I will say, given who brought us together here, I would say one specific option is to get a consult about a kid that, if you have questions about this, get a consult from, do you guys call it MCPAP? Anyway, the Massachusetts Child Psychiatric Access Program. Right?
Yes, Michael. It's called MCPAP, and that's
all right, MCPAP. Okay. So I'll I know it's 1 o'clock. I gather that we have a little bit more time, so I will try not to crowd all of that out. But there are a few more things I want to say, and then we can see if people have other questions. Next slide. Identification, as we've discussed, identification begs the question of how to treat. So our toolbox for treating acute suicide risk is limited, also, but not as limited as one might think. I already talked, some people, well, everyone who endorses suicide risk, you have to keep them safe. In the clinic, that might mean that some people need to be held somewhere where they can be watched. In some cases, that means they have to be hospitalized. And in some of those cases, even they have to be hospitalized against their will. But most people aren't that acute. So you know, you want to take some next steps. In the practice, you want to reassure yourself that the patient can be discharged, and you want to plan for what to do after discharge, but you don't have to default, as I said before, to you know, sticking everybody who's positive in an ambulance, and it would be probably counterproductive if you did. So the slides are a little bit out of order. I'm going to talk about a few different options here, but this slide shows some specific strategies based on principles of dialectical behavioral therapy that one can offer directly to someone in crisis. I will say these aren't strictly evidence-based in the sense that, you know, the first bullet here is that people should kind of reset themselves emotionally by showering in cold water or sticking their face in ice. Again, that's a component of dialectical behavioral therapy. I can't say that it has been tested in RCTs, but you know, until we have that kind of evidence, this seems like has face validity. So next slide. An intervention that can be offered within the clinic during an index encounter in which somebody is identified with suicide risk is something called safety planning. And this slide is an example of the safety planning intervention. Safety planning is a kind of problem-solving strategy that a member of the clinical staff, a nurse or a social worker or somebody, can do during a clinical encounter in which someone is identified with suicide risk. It involves a combination of it walks the patient through some practical steps that they can do, that they can take. The parent can be involved in this, you know, for kids and you know, under the you know, appropriate when the person is returning to a family home. The safety plan includes specific steps to make the environment where the patient is returning to safer, locking up or otherwise removing firearms, medications, other hazards that could be used, other lethal, so-called lethal means that people could use, you know, to try to harm themselves. And it also includes written enumeration of coping strategies that the person can document for themselves. These are personalized strategies for what to do in the, you know, when they are out in the world and feeling in crisis. And it can take broadly two forms. They can write down things they would like to, that they should avoid because they increase distress. You know, don't hang out with these friends or those friends, you know, avoid drinking, that sort of thing. And it can include strategies that can reduce stress, things they like to do, pleasant events, kinds of things, or you know, constructive coping strategies, people that they should contact, or things they could prompt themselves to say, reach out, and so on. Again, the document here, which there's a link to at the bottom, is a particular example of a worksheet. Safety planning is done collaboratively, and the patient should leave the clinic with a copy of the safety plan, a physical copy of it. Okay, next slide. Okay, so again, the slides are kind of out of order. So here's additional information that one can give to someone in crisis. These are resources that people can turn to themselves if they, you know, if they're in distress and they need something right away. Could you jump, please, to the next one more, and then we're going to go back. Okay, so finally, this is the one slide, aside from disclaimers, that actually is bullets and text. So, I mean, I've mainly talked about briefly things that happen within the encounter. For people you put in an ambulance and they go to the hospital, then you're handing them off physically to a different care system. For patients that you discharge home, the practice, what we have learned consistently is the most essential thing in that situation is for the treating clinician the practice to stay proactively engaged with the patient. The traditional kind of gross medical model of sending the patient home with instructions and leaving it to the patient or the patient's family to follow those instructions just doesn't work for this type of thing. So ideally, where the resources are available, effective care includes warm handoff to appropriate outpatient care in communities where these resources are available and where the patients can pay for them and so on. There are indicated psychotherapies that are with demonstrated effectiveness for reducing suicide risk, in particular dialectical behavioral therapy and suicide-focused CBT. I do recognize that there's a shortage of providers like this, and also that many pediatricians don't currently have active working relationships with mental health specialty providers in their area. So it's easier to point to these things and to invoke them for patients than to actually furnish them in real life. In any case,
if I could
yeah.
just interject for this particular audience, all of the pediatric practices that are involved in doing this work in Massachusetts have access to help, in terms of getting those kinds of referrals done, because our program offers not only consultation but evaluation and also some help with resource and referral and navigation.
So that's really wonderful. I mean, it's really wonderful for patients. It's wonderful for providers, and for the purpose of the current conversation, it's also wonderful from my perspective because it checks off one major barrier to people being willing to practices being willing to screen proactively, right? Because MCPAP is part of the answer for what to do when you find somebody who's positive.
Yeah, exactly. Actually, that's been our experience as well, because we've had a significant role in really helping to make the universal screening practices in Massachusetts to actually happen, and because we're able to help people to address positive screens, and we've also done a lot of work to educate practices in terms of how to screen.
So that's great. So I'm going to finish. If you can go back one more slide, I'm going to finish with one more thing. No, backwards. That. Okay. So I'm going to finish with one more thing because I think it's a really powerful story in my view. So it turns out there have now been multiple randomized control trials of demonstrating the effectiveness of an intervention that is so unintensive, so light touch that you might be surprised that it would have any effect at all. So the intervention is called caring contacts, and what it has involved mainly has been following up after discharge from an emergency department visit in which someone was identified with suicide risk. If in the months, 6 to 12 months, after that type of healthcare encounter where someone was identified with suicide risk, if in the next 6 to 12 months, one reaches out proactively and repeatedly to the patient with simple messages of encouragement, what we have found is in that next year, the rate of additional new suicide events, attempts and deaths falls by 1/3. And what's on the slide here is a postcard, a literal postcard that was used in one of these trials. This one was done in Australia, where the team, this was based in a hospital emergency department, sent this postcard to patients 6 times over the course of the year. It was the same card. And the end result was that the patients who received this intervention had 1/3 fewer suicide events in the next year than the control patients who didn't receive this kind of encouragement. This has been tested in multiple trials. It's been delivered via paper communication. It's been delivered now via text messages. It can also be delivered via telephone follow-up, which is a slightly different intervention but serves the same purpose. And again, consistently found that just doing this, proactively reaching out with messages of encouragement, not even demanding and, not even to nudge the patient to engage in follow-up care, but simply to say, hey, we're thinking of you, that has a substantial effect on reducing subsequent suicide events. And I want to mention this. It hasn't been tested in pediatrics, but I want to mention it because, if we can reduce subsequent suicide events in people with acute suicide risk presenting in emergency departments with something this simple, I think it follows that we can and therefore should look for more people to help and figure out how to help them with available technologies, and that we have some reason to be optimistic that doing so can really make a difference. Let me close there. My contact information is on the very last slide. There are a couple of more resourcey things that I have in the slides at the end. You can look at those. I'm running out the clock, so let me just shut up and see if in the last 5 minutes there's still other questions.
Thank you so much, Michael. That was a really great discussion or presentation, and we just have a couple more minutes. So if there's still time, if anybody types a question into the question section, we'll see it and we can read it and hear what we have to say. So we'll just wait another minute or two to see if anything.
I've bludgeoned people into numbness.
I'm always impressed, Michael. You say that you're not a clinician, and I know you're not a clinician, but you know a lot about clinical work, and so it's pretty good. You could be like deputized or have an honorary status. So there is a question. So from Kathleen Herzaya, just asking about your thoughts about how to explain positive screens to parents, which is a clinical question, I suppose.
Yeah, and it's a question sufficiently clinical that I don't know how to answer it. Actually, I'm embarrassed to say.
Yeah. Maybe I should speak to it. I mean, we've done this quite a bit, and there's no one answer to that question. But I usually start by negotiating with because you want to talk to the teenager, the child first about their answers, to the questions and about what's going on, and part of that conversation is negotiating with the teenager, usually a teenager, about how they would like this to be explained to their parents, and to try to have some agreement about that, and obviously sometimes they don't want to explain it as much as you might want to explain it as a clinician, and so it is a negotiation. But I do like to give the adolescent a voice and in terms of how that's explained, and then I go from there, and there's certainly a delicate process there, because parents often, as you say, don't know, and so it's devastating oftentimes to parents when if they hear about this for the first time, and terrifying, to them as well. So you do have to be prepared to support the parents and then try to move the discussion into a safety planning and sort of mode, and to talk about what to do, because parents are not going to be able to sit with knowing about this risk for very long before really wanting to talk about so what are we going to do here. And again, MCPAP is available, as always, to help to discuss these things and to coach you as primary care providers, to help you prepare for those kinds of conversations. I'm afraid we've run out of time. It looks like there was a question that was squeezed in at the end about the role for youth development specialists, if they are concerned, and there certainly is a role, and perhaps we can answer that offline for the audience. But I'm afraid we're going to have to stop. Thank you very much, Michael. This was a really, really nice presentation, very, very useful. And thanks everyone for attending. Further questions can be emailed to mcpap@beaconhealthoptions.com. And please take a moment to respond to the survey that'll pop up, and remember that there's a recording available. So tell your friends. So thanks everybody, and we'll hopefully see most of you for our next program, which will be sort of announced over the email listserv. Okay.
Thank you.
And also just a reminder that because of Christmas, we will not be having a clinical conversation in December.
Yes. Thank you, Beth.
You're welcome.
Great. Okay.
Okay. Thank you all. Bye.
Thank you.